So Maura and I are going to present today on the SOS approach to feeding, and this is a 4-day conference that we both attended, given by Dr. Kay Toomey, that just talks about one of the approaches to feeding. So we'll talk about that, and the whole time that we're talking, just be thinking of a kiddo that you guys can envision and think in your head how some of these approaches might work, and then at the end, if we have time, we can share some of that, and if there's questions, we can talk about that. And I'm Megan. This is Maura. I'm Megan Wilkins. I think I know most of you guys. We're both OTs here. So Dr. Toomey put a disclaimer up there that the talk is being given with permission from Dr. Kay Toomey. She's the owner and developer of this SOS approach, and she holds the copyright for all these materials. So SOS Approach to Feeding, it stands for Sequential Oral Sensory, and it's designed to assess and address all the factors involved with feeding difficulties. So we're really looking at the whole child here. So it's philosophically based on the idea that the child is always right. We're following the lead of the child all the time. And it's based on 4 major tenets or principles. So the first principle is that the myths about feeding tend to interfere with understanding and treating feeding problems. And the second tenet is systematic desensitization. It's the best first approach to the feeding treatment. They're not claiming that it's the only feeding approach, obviously, but they feel like this is the first approach to try before moving on to some of the other approaches out there. Tenet number 3, the normal development of feeding gives us the best blueprint for feeding treatment. All kiddos develop with feeding on the same milestones progression. So they're basing it on that blueprint. And number 4, food hierarchies and choices play an important role in feeding treatment. So you can achieve sensory and oral skill progression with food choices rather than doing to the child. So they definitely are not of the mind that you go in and you use your nook brushes or vibrating tools on the child. And food hierarchies can help sensory systems shift slowly into accepting new foods. And we'll get into all this in detail with food hierarchies and how that works and looks. Okay, so we're going to move on to the 10 myths of the mealtime.
Okay, so there are 10 myths that the SOS approach has identified that kind of interfere with being able to treat the feeding aspects, and a lot of our families and parents, you will, as we go through them, you'll realize really do believe a lot of these, and so this will help us in talking to them about these myths. So the first myth is that eating is the body's #1 priority, and actually breathing is our #1 priority, and our second priority is postural stability. So if we don't have those two, we're not going to be eating. We have to protect ourselves from falling on our head, and we have to be getting air and oxygen to our brain. The second myth is that eating is instinctive. And then the third myth is that eating is actually that eating is easy, where it's actually the hardest thing we do that involves all 7 areas of human function, from sensory, all of our organs. So we'll get into all of these as we go. Myth number 4 is that eating is a 2-step process. Lots of people believe you sit down, you eat. That's what a lot of us do because it's natural and automatic for us, but for a child learning to eat, it can actually be between 25 and 32 steps. And we'll get into those as well. Myth number 5 is that it's not okay to play with your food. And I think most of us know that it's very important that we're playing with our food because eating is a learning process for the kids. So when it involves interaction and all of our senses, we're going to be learning a lot more. Myth number 6 is that if a child is hungry, they will eat, and that they will never starve themselves. I've had lots of families and parents say this, so they'll just eat, they'll get hungry enough. There's actually a lot of research to back that there is a percentage of children who will not eat. Doesn't matter how hungry they are. Myth number 7 is children only need to eat 3 times a day. But they have little tiny tummies and they're busy running around, and they actually need to eat between every 2.5 to 3 hours a day. Number 8, a child who won't eat has either a behavioral or an organic problem. And we actually know that about 10% have a actual medical issue that's keeping them from eating that can be fixed with a medicine or a surgery or something, and then it's over. And then on the other end, there's about 10% where it's environmental, where you can change something in the environment. But the majority of the kids, it's going to be a large combination of everything. Number 9, certain foods are eaten only at specific times of the day, and only certain foods are healthy for you. And this is, this is more of like a cultural belief. So in different cultures, we eat different foods at different times of the day, and it's just kind of trying to make sure we realize that any food can be eaten at any time. It's just food. Myth number 10 is that meal times are a proper occasion, and children are to mind their manners at all meals. And it's a learning occasion, so kids learn best by play, so we want to remember that. Okay, we're going to go a little bit deeper into some of these myths. So going back to number 1, that the myth is that eating is our number 1 priority. Where in fact breathing is our number 1 priority, and postural stability is our number 2. Eating is our 3rd priority. So we're going to do a quick little exercise so we can kind of see how it feels to not be able to breathe very well. And I want everyone, while we're doing this, to kind of just take note of your physiological responses. So if you have somebody close by, you can just get a partner.
I guess she's going that way.
So one person will participate in the exercise while the other person kind of observes them. So I'll just explain really quick what we're going to do, and then when I say go, you can do it. So you kind of want to be able to see your partner in the eye, if you can. And you're going to so decide who's gonna be the one first participating first doing the exercise.
She's gonna tell us.
Okay, and then what we're gonna do is we're gonna inhale and fill our lungs all the way up as much as you can. Take the deepest breath that you can, and you're just gonna hold it up there at the top. And you're gonna hold it until I tell you you can begin to exhale. While you're holding your breath in, I want you to just maintain eye contact with your partner and try not to look away, and just take note of any physiological responses that you're feeling. And then the person who's observing, watch the other person for those physiological responses as well, and then we'll switch. Does that make sense? Mm-hmm. Okay. I think some people hold their breath.
Don't start yet, or you'll die.
Okay, go ahead and take in a deep breath. As big a breath as you can. Expand your lungs as much as you can, and just hold it right there. Don't exhale until I say. Maintain eye contact with your partner. Try not to look away. Take note of how your body is responding. The person holding their breath. Okay, go ahead and start to exhale slowly.
People are like,
Are you not doing it too? Did you watch her turn red? Harder and not to blow.
Nobody talks about it. I know. Okay, now let your partner have a turn. So go ahead and inhale. Open up your lungs. Hold it. Hold it. Maintain eye contact with your partner. Okay, if you go ahead and exhale.
like
a little
diet
bit.
Okay, what did you notice about?
I didn't want to look at you. I know
What did you all
that.
notice about how you felt?
Yeah.
Just from a physiological
I heard Nadine say anxious. She felt anxious.
Woozy.
tight, like your chest felt tight.
Yeah, my belly felt tight.
Anybody else? How you felt physiologically?
I kind of felt fidgety.
Yeah.
I was distracted
Distracted?
Yeah.
to think about
Yes.
having something else unattractive.
So we kind of had you try and maintain eye contact with somebody as a small kind of skill to be doing during the activity, so you couldn't just focus on holding your breath. You kind of had to focus on something else. So imagine a child who's having that hard of a time breathing, and then they're asked to look at somebody, they're asked to try something new. So it's just good to keep in mind that how important breathing is. Some other things you might take note of in kiddos when you see them, if they're starting to sweat, turn a little bit red, increased heart rate, if they get the hiccups a lot or yawn a lot, if you're noticing retraction or elevation, kind of the shoulders or the upper body, tight jaw, and then fidgety and stiff also are signs of just they needing to be able to breathe.
And another thing I feel like you notice too, like if it's a baby on a bottle, is that suck, 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 breathe, 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 suck, 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 and it's almost like they're drowning, and you're just they're congested and their noses are plugged and they're putting something in their mouth. So you're watching for how many successive sucks they have before, and then lots of breaths after that. Just for the younger kiddo.
Yeah, definitely.
Maura, could you go through that list one more time?
Yes, so sweating, redness, increased heart rate, hiccups, yawning, retraction and elevation of the upper body, tight jaw, and then if they appear fidgety or stiff. And then going into postural stability which is our second priority. So it's our second priority because we're protecting our brain and our head from falling. Stability it also frees up the motor part of our brain to focus on the task of eating. It provides security within our seating arrangement. It allows, for that better hand-to-mouth coordination. When our core is stable, we can freely use our arms. And then range of motion also with the jaw and the tongue. So talking about children with low muscle tone. So some signs of low muscle tone while they're sitting at the table might be that they're slouching, they're propping, so they're either sliding to the side and using the side of their chair, or they're putting their arm up and leaning on that side. They actually might lock their joints out, so to compensate for that low muscle tone, they're locking out and they might appear stronger, but actually they have low muscle tone. Sliding out from underneath the table. A lot of kids with low muscle tone will prefer to stand or to prefer to be constantly moving because they're compensating for that static stability by moving dynamically. So when they're moving their muscles, they don't have to focus on just standing and eating. So we're going to do another activity for the for postural stability. So pass around crackers, but if you have something else you're eating, that works too.
Remaining chocolate chip. There you go.
So you just need like one cracker.
Here you go.
One or two. I can probably not share.
If you're hungry, take some more.
Sign up sheet. Thanks, Lori. Joyce, can you grab that from Lori?
Anybody else want a cracker? That's a good one.
I almost did that. I was like, it's really hard not to get a cracker with this in your hand. I know. You're right. Yeah, it's in my hand. I do not need SOS. Your hair's cute. Thank you. Behind on schedule this morning. It's just. Oh, I like that. Doing its own thing. I like it. That's good.
She shouldn't say anything.
God bless you. That helps you.
Maybe it is, it's fine. Okay, so does everybody have their cracker or something they would like to eat? Okay, so think about a child you've seen with low muscle tone or a child that you've worked with, or if you can't think of anybody, then just lift your feet up off of the floor and hold them off the floor while you take a bite of the cracker. Or, you know, if you can picture a child who slouches to the side or sits on one foot or whatever, you know, play around with it and just
A visual impairment, whatever you guys want to do.
take a bite and then see how much harder it is to bring the cracker to your mouth while your feet are in the air, or how much harder it is
I don't have a problem.
and move your around.
I think I'm an expert eater. I think I eat on the couch too often. We all do. I call this one of my strengths. Right. Close your eyes. I can still find my mouth.
I can too, but when I was over the side, I lost my balance. I mean, you know, and so I have my.
This is from eating in bed watching TV. I know, I was gonna say, like, with my feet up on the couch.
It's a good way to work your stomach muscles, isn't it? It is. Just even doing this. Yeah.
Okay, does anybody have anything to share for how it felt to eat something with your feet off the ground or slouched to the side?
Closing your eyes in addition to that was,
That's a good
because
one.
I found when I was really moving off to the side, when I closed my eyes, I lost some of my stability.
Yeah, 'cause you use
Yeah, it did. And then it was like this came out of my mouth and.
did it.
I have a foot cancer, so I'm back to the
Oh.
this.
Oh, yeah.
He doesn't last in the hydro very long, and now I know why.
Uh-huh.
He has tons of small little meals, and I get it now.
Oh, yeah.
That's tiring.
Well, that'd be hard to hit your mouth if you're up and
And
down
that
all the
could
time.
be part of that compensating with the dynamic
Yeah.
movement
Yeah.
for the stability.
The always moving.
That's a good thing to keep in mind. And then like Sue mentioned, like we're expert eaters, so it's a little harder to. Like we've been doing it, you know, it's automatic task for us. So think about a child who it's not an automatic, like they're needing help already, and then they have these other issues to deal with too. So looking at positioning is super important. It's the first thing we should be looking at when assessing a child who's having difficulty eating. How are they positioned? So this is the correct positioning, and it's termed, you might hear the term 90-90-90, where the hips, the knees, and the ankles are all at approximately 90 degrees. And in the first picture here, there's a something behind the child's back to support, so that to make up for all that extra space on an adult-sized chair, and then something positioned underneath the feet as well. And then in the second picture, that child is seated in on like a sassy seat or something that clips on to the table, and then there's something to support underneath the feet. So in the SOS approach, they recommend the sassy seat a lot as a good, because they are right up to the table and their arms are free to be at the correct height, as long as the seat, I mean, there's a variety of seats on the market, but as long as the seat is stable.
But you have to provide the support
Under their feet, yeah.
independently.
Yeah, and a lot of times they'll stick a chair or a stool, or, I mean, they had pictures of, like, dads who built, like, even a little thing that comes out from the island under the seat for their feet to rest on.
And a lot of times too with those seats, just in case they were to disengage from the table, they put a chair just under the seat.
Yeah.
So if the seat or if something were to happen, or you have a mover and a shaker in that chair, there's something that they could fall down on, just a little safety side too.
And then the next slide is just the incorrect positioning, which is what we see all the time, is the booster seat or the seat with the feet up, or even like a high chair that sits on a seat that doesn't have any foot support. So just keeping in mind, especially the feet. What are the feet doing? Are they dangling? Are they propped up and they're at this tight angle here? Are they hanging down? And how can we adjust that? So a few seating recommendations are that non-skid mat underneath their seat, so it's not sliding. A lot of times, just a shelf liner will do the trick. The footrest, which we talked about. Side supports are really important, especially for those kids with the weaker core that tend to do this. And then these are some for the infants who are just starting purees, sitting up in the high chair, it's recommended that they have a semi-reclined position so that their head and neck are supported so that they can begin to learn to use their jaw muscles. Up until 8 to 9 months of age, and then an upright position up until 14 to 16 months in a high chair, and then after that the sassy seat or some kind of booster seat where they are in that 90-90-90. But it is important that they're up at the table beginning around 14 to 16 months versus having a tray and sitting separate from the family, just because of where they are developmentally and cognitively. The best bet is to be sitting up at the table so they can benefit from modeling.
And if anyone has any seating recommendations that they've used in a home that you feel was really great and accommodative, because you're in the situation and you have to find those side supports and you have to find the things that go underneath. So if anybody has suggestions or whatever, or things that they've used that have been helpful, feel free to share. Because I know going out with PT, sometimes I'm looking at one thing and they might notice, they need some side supports, and we're rolling up all the towels in the kitchen and we're putting them on the sides and we're grabbing, liners out of the kitchen cupboard and like trying to put it under their bottom and whatnot. But you kind of get crafty when you're in the home, so it's always fun to know what other people come up with when they're there. So if you think of something, you can share it later.
Pool noodles are good. You can cut.
Yeah. What's that?
Pool noodles
Yeah.
are good.
Yeah, like for the side supports.
Maybe a little firmer.
Yeah, they are.
Yoga
blocks.
Yeah, yoga blocks.
That's a great one.
Phone books.
Love phone books with duct tape around them.
They're not, we don't have phone books.
I know.
I know, I saved one just for that.
A couple.
I did too.
Phone
books.
Oh,
Yeah.
Get big phone books. We got a grandma's encyclopedias once. She was like, I'm not using these. I was like, yes.
I still get them, but it's
Okay,
such a
so
waste.
our second myth was that eating is instinctive. Eating is driven by our appetite instinct for only the first 4 to 6 weeks of life. Then eating is driven by our primitive motor reflexes until about 4 to 6 months of age, which is typically when we start purees. So after 6 months of age, it is a learned involuntary behavior. So it's normal to see some rejection at that age. And the issue with learning to eat a new food once we have voluntary control at that 4 to 6 months of age is that rejecting a new food is actually our natural evolutionary response, because it could be poison. So naturally, a child is going to give you that first food. You can go to the next slide. They're going to give you that face. And everybody, we've seen it, when they first try a food. So that's why it's really important to offer foods over and over again. They recommend that 10 times before a child is going to be accepting of that food. And then you can go back to the other slide real quick again. So kind of going back to our psychology, classical conditioning is, Pavlov's ring the bell and they salivate. It's a body-based learning. Our operant conditioning is where we provide a consequence to what is happening in the situation. So some examples of this is if a child eats a food and they receive praise, they're likely to eat that food again. If a child eats a food and they choke, they're likely to not want to try that food again. And then if a child refuses a food, they receive attention, they're likely to refuse another food. So that's our upward conditioning in that area. You can go to the next slide again. So naturally, babies are gonna be making this face when they try new food. With positive reinforcement in the second picture of praise, smiling with every, trial, they're conditioned that this is an okay thing to try.
Okay, so we're moving on to myth number 3, that eating is easy. And so, why is this false? It's because eating is one of the most complex tasks we can ask a little kiddo to do. It's the only human task which requires every one of our organs, and it requires all of those systems to work together and to work correctly. So every muscle in the body is involved, and they gave the example of like a swallow. For just one single swallow, it involves 26 muscles and 6 cranial nerves. So just to swallow, this kiddo is working, so we're all working very difficult, and it's very, very hard. And it's the only task that children do that requires simultaneous coordination of all of our 8 sensory systems, as well as learning, development, nutritional status, and the environment. And it all has to be integrated to make sure that a child can eat correctly. So feeding we're looking at is really the tip of the iceberg, or the summit of that mountain. Like, we're gonna get that child to eat after we address all these subcategories, which is a lot. And sometimes it takes a long time when we're going into a home to even get to that actual eating, which is really tough for parents sometimes. Okay, so moving on. Oh, and this just goes over our different sensory systems, so looking at smell, taste, hearing, touch, vision, our balance, body awareness, our interoception, proprioception. Those basic sensory systems are also a huge component of this hierarchy to eating. So myth number 4 is on talking about eating being a 2-step process. You sit down and you eat, and this kind of goes back to what we were talking about. For children that have challenges with feeding, it can be a 32-step plus. There can be 32 steps or more, and for a typically developing child, it's usually about 25 steps. So you're still looking at a lot of steps in the process to eat. So these are the 6 main categories that they talk about, but underneath all of these categories, there's subcategories. So this is one of my favorite go-to handouts when I'm working with families, because feeding is such a slow, emotional process for families. By the time we get in, lots of times there's a lot of emotion wrapped up around this. There's a lot of beliefs, a lot of cultural things going on. And whether you're in coaching or you're in as a primary, the parents really want this fixed really quickly. And so the patience is kind of gone. And so looking at, okay, here's all the things that need to happen before we can get to that tip of the iceberg or the summit of that mountain, which is actually eating the food. So I like to bring this one in, and we don't have that, I think, but we can get it to you. But this is all the subcategories that then get you up to eating. It's not on here as a slide. I just love this sheet because this is like, there's 6 steps, but this really gives you the visual. And I've actually had some breakthroughs with families where it's like, look at this. Like, and so when we go in and start really we've kind of gone down the physiological route and what's going on with the fundamentals, with the health and all of that, and why are they not getting past where they are. So we look at where they are on day 1 and what are they doing. Are they tolerating you microwaving or getting that bottle ready, heating up that bottle? Are they tolerating you preparing the food? Where are they with all of that? And writing that down here. And then, in a couple of weeks, we look at it again and like, wait, they did make some progress because now they're in the same room when you're making that food versus downstairs because they were gagging when they smelled that food. So just really showing them those really small differences that can exist with feeding and those little tiny successes. And lots of times it's awesome because you're starting up here and then the parents are like, really? Already are doing all of this and the kiddos are already bypassing these bottom steps. So there's also successes that can be shown with them in the progress with this.
Do you want me to make copies of that?
Yeah.
Sure, that would be great.
They're all frothing.
And we're not even eating.
Hey,
Maybe that could be added.
did you want the whole one? Because I have the whole one.
Which whole
With
one?
all of the subcategories behind
Oh, that's the one I was just showing. I
Yeah.
think you mean the ones that go underneath here?
Yeah.
Yeah, that's
Okay,
the one
cool.
that Monica's gonna make a copy of. Yeah. So, that's something that talked about. So the tolerance, so we go down to tolerate, and I touched on it briefly, but that they can be in the same room as the food, or the food can be at the table, but is it an arm's length away, or is it in front of them? What's the proximity at the table? So that tolerance level. Mom was telling me the other day about a kiddo that, well, it's kind of more up here to smell, but she has some significant feeding challenges, but they go to a certain restaurant, it's a certain Thai restaurant, and that kiddo can have eaten 45 minutes before, and this is a family that has that kind of food in their home all the time. They walk in that restaurant, and she immediately gags and vomits. Just from that, and her mom's like, it's not that she had just had a full bottle or anything. Dana, you know who I'm talking about, this is one of our little ones. And so it's just that sensory system is so on overload and it's just that association also with some of the really big challenges she had early on with feeding and still continues to have. So that's the tolerance piece, and then we move on to interacting with the food. So how are they interacting with it? Are they touching it with a utensil? Are they putting a napkin over it and moving it around? What does that kind of look like? Is it coming to their skin, or is it just going onto a utensil instead of their skin? And then tolerating the smell or the odor of the food.
I remember them saying smell and interact can be switched a lot of
Okay.
times for kids on the spectrum.
Okay.
So sometimes they can smell it before they can touch it.
I believe that,
That really makes sense. And that's what it talks about, how this usually is progressive, and it usually looks pretty progressive
Or
as
before
they,
they can
with it. What's that?
not touch, sorry, I meant interact with.
Interact with it, yeah. So like usually it's progressive and it kind of does look like stepping stones for them, but at other instances, it might be that they kind of go up here first and then come back down. So you're always looking for that and looking why, and also looking at the whole kid and why is that whole kiddo and why is that happening.
And sometimes they skip and keep going, and
Right.
it comes naturally.
Yeah, and as long as they don't come back down. Because they'll talk about, it depends on that day too for the child when you're there, when the family's having the meal, what happened earlier, are they up here sensory-wise, or they not pooped in 2 days, so, their meal looks a little bit different. So it's that idea that Maura talked about earlier too, just that continual exposure, and there also are some of those natural humps that kids experience that are age-appropriate and developmentally appropriate, that they are not eating what they usually eat or whatnot, which we'll get into more later. Okay, so then moving on, so smelling, touching, where are they touching that food? Is it just at the end of their finger pads? Are they able to move up pretty quickly up the arm? And that's where I like to start with food play, if there's a really, really sensitive kiddo, starting at their fingertips, and then we might take something up to our elbow and catch that in our elbow, and then you just slowly, progressively work up towards the mouth and get near that real scary place, where that food needs to go. It's a really scary thing for some of these kiddos. So just moving slowly, and if you notice that something changes even physiologically with them once you get up to the elbow, you bring it right back down to their hand and get that away from their mouth, or near their mouth. So that's how slow it can work for some of these guys. So that was touch, taste. Wow, that's a big one. So how is the kiddo actually getting that food on their lips or around their lips? So it might be that, they're taking a hard meltable or a munchable or something, and they're painting that food on their lips or around their lips or on their cheek. Or eventually the goal being that it gets in their mouth and they eat and they have made it to the very, very top of the mountain, or the iceberg there. So that's just, I think, so telling about how difficult feeding is. And this is just a quick little reference for parents to be able to see and also gauge the progress that their kiddos are making. Thanks, Monica. Okay. So they kind of skipped over 5, so I'm just going to talk briefly about it. So myth 5, which is not up here, but it was talking about not appropriate to touch or play with your food. Obviously, everything we just talked about is one of the more important things to do, and I think that's a tough thing too, as providers going into a home and respecting parents, their own sensory systems, and also their own cultural beliefs as to whether or not their child gets messy when they're eating. When you're sitting there as the provider and the parents taking all that food that lovely, like, fell on their face, and you're like, yes, they're going to get their hands up there, and they're going to get that food in their mouth, and it's going to be awesome, and the mom's taking that spoon and, like, scraping it up their lips, and you're like, ugh. So just having that conversation, and there are some parents that can't get past that. It would drive them crazy to have their hands messy, and so you just find other ways. So we've talked about, bringing toys, like what do they mouth? What will they safely put up that's maybe a non-nutritive item to their mouth? Whether it be a rattle or one of those Sophia little drops or whatnot, and bringing that up to the high chair tray and letting that get dirty and eventually get to their mouth if the parent can't handle the child getting dirty, or their hands getting dirty. So, yep, getting messy is a good thing. So being messy is important, and that's a great way to learn to eat. Myth number 6 is a child is hungry enough, he or she will eat. They will not starve themselves. And I think this is another really important one, because I don't know how many times we hear that. Like, well, they'll eventually eat, and you hear it all the time in all areas of our life, and you're just like, ugh. So there are some great statistics here about that, but that's true for about 94% of our population. And the other 4 to 6% of the pediatric population who have feeding problems, they will starve themselves. And it's usually inadvertent, but they will. They put that protective response up and they will starve themselves.
What's the FTT?
Oh, sorry, failure to thrive.
Failure to thrive.
Failure to thrive.
NFTT.
Yes, and NFTT is non-organic failure to thrive.
Non-organic.
Which I
like
will say is
sensory,
an auto qualifier for a toddler as you prepare to start doing eligibility evaluations.
So-
Right there,
So
What's
that,
non-organic?
is that, there's
Like
just no.
sensory based, or
Oh,
it's
sensory.
not, there's not a medical
Physiological,
diagnosis.
something like that.
Okay.
It's just like, we don't know it.
Non-organic.
Environment.
Non-organic is fancy, they're saying we have no idea.
So for the majority of the children with feeding difficulties, eating doesn't work and it hurts. So no amount of hunger is going to get them to eat or overcome that fact. That's just the way children are simply organized. It's awesome. If it hurts, they don't do it. How plain and simple is that? If it doesn't work, they cry and run away. So wish we could do that. So for children who have skills
We talked about
or
that
medical
yesterday.
problems with eating, their appetite often becomes suppressed over time. So they no longer respond correctly to the appetite stimulant and the cue to eat. And then they have the insufficient number of calories. So there are some, if you have a family where they are pretty they like research and they like to know, sorry, Steve, I didn't want to stand right in front of you. This would be a good place to go to on the slide, maybe look some of this up and let them know that they're, right, to go to your handout and flip that up if they need that. To help them understand that they, skipping those bottles, or within G-tube kiddos, they've proven that as well. You skip a feeding or whatnot, it doesn't mean that child's going to eat more out of the bottle. They're probably going to eat less because they don't feel good. And that's stated very generally, Dana, I know. Dana's a little sometimes, but that's a very general statement right now. So myth number 7 is that children only need to eat 3 times a day. I think they skipped it on here, but the idea that children need to eat 3 times a day, and Maura touched on that is not true. Their tummies are too small, they would have to eat 3 large meals like we do a day to get the calories that they need. So they need 5 to 6, we call them mini meals, where it still can be a meal that's packed with the protein, the starch or carb, vegetable, fruit, if you can do that. If you have the time to sit the child down 5 times a day or 6 times a day, but trying to look at those as 5 little mini meals rather than 3 big meals for the kiddos. So that again is false. Okay, myth number 8, it's either behavioral or an organic problem. And this is one that you hear a lot too. It's like, well, it's just their environment. I think it's the environment that is causing this. And it might initially be the environment, but over time that environment is going to have a big effect on their appetite and their nutritional status. So they really are like yin and yang. They go hand in hand. So there's a lot of research studies and data from their center, from Dr. Toomey's center, that indicates that between 65 and 95% of all children with feeding problems have a combination of both the behavior and the organic problems. And if you start with the physical problem with eating, you're going to quickly learn that eating doesn't feel good, and it hurts, and there's the set of behaviors, and you avoid the whole activity altogether. And then if you start with purely the environmental or behavioral, and that's the reason you're not eating, you're compromised your nutrition status, and the lack of experience begins to cause all the organic problems. So what I was just saying. So it's really not great to create that dichotomy between the two. It's not the chicken or the egg. They're usually both playing a part in it. So myth number 9, certain foods are only to be eaten at certain times of the day. So there's breakfast foods only for breakfast, lunch foods only for lunch, snack foods only at snack time, and on and on. And certain foods are good for you. Food is just food. crackers are just crackers. Monica thought that was my lunch. She saw the box of crackers and she thought that was my lunch and was a little worried. And I'm like, food's just food, Monica, that's what we
I was silently judging.
Joy carbonation.
Something, didn't she?
And I'm like,
She's sick. So, you know, food's either a protein, a carb, a fruit, a vegetable, looking at it that way. Some do have more nutritional value, but we don't want to get in the habit of labeling food as good or bad. That's just not helpful to a child. Again, food is food, and if a child eats those chicken and peas at breakfast the best, then let them eat them at breakfast. Don't get caught up in when they should be eating them. And that, you know, what we refer to as junk food is actually a really nice tool for stepping stones for developmental eating, and they just have those really nice characteristics sensory-wise, and then how easy it is oral and motor-wise for kiddos to eat. So if you think about some of those soft meltables, usually it's hard to find a real healthy soft meltable, but just the characteristics and quality of those are really great beginning things for kiddos that then they can move on past that. And they won't just be eating cheese puffs the rest of their life, you know. We can assure parents of that most of the time. Okay, so myth number 10. And then on number 9, just really quick, you don't have to go back, but I think Ellen Satter does a great job. The Ellen Satter website is awesome to kind of touch on a lot of that, about where you place foods in the hierarchy of foods and just letting food be food, and going into depth about family style eating, which I think is a huge, wonderful piece for families if they can adapt that model. It really helps incorporate a lot of the SOS approach. So Ellen Satter is a great resource as well in that area. So myth number 10, meals are a proper social occasion. Children are supposed to mind their manners at all meals. So eating comes first, manners are second. So the skill for eating needs to be learned first, and then the children can have good manners. So if you think about the 6 to 9 month old infant just learning to eat, how messy they get, as well as children who have not learned to eat well, mealtimes are that teaching opportunity. And as parents and providers and caregivers, they are the teachers during that time. So they talk about the show and tell time, keeping meals about the food that you're eating. So if you're looking at your plate and what's there, it's, you know, oh, I have something red on my plate, looking at where the child is cognitively and developmentally. You know, who has something red on their plate, or I'm going to eat my red pepper, it's going crunch, took 3 crunches, or where's my red pepper, it's on my back molder. So really using it during family time to kind of incorporate a little bit of play depending on where they are and taking that opportunity. So again, using the home-based model is how you don't have to have a separate 20 minutes set aside to do feeding therapy. You can do it during meal times or at snack times or whatnot, and just incorporate it that way. So those are the 10 myths in depth a little bit. And I just think they're great strategies to bring, or great things, resources to bring out with parents. So red flags, this is just, red flags is just the basic red flags. You guys can kind of, since we're running low on time a little bit, you can read through them. I don't really need to read them with you, and then we'll go in depth about a picky eater versus a problem feeder. So basically these are red flags, and this is when if you're doing a evaluation or whatnot is appropriate for a referral. And that's why I like that next handout, the picky versus problem feeders, and looking at whether or not is that a child that's appropriate for a therapy referral. Is it just a picky eater right now and they're at that stage where they're going to come back around. So it kind of gives some details on that. So if you guys want to,
and I think this is going to be, just to kind of tag with what you're saying, I think that's going to be great information, because kind of the way it stands right now, whenever we get a phone call from a parent to take a referral and the concerns are eating, we evaluate all of those kids. We will always go out and do an evaluation, because we don't feel like we can get a good feel for an over-the-phone conversation. So you guys are going to see a lot of these evaluations when you start doing eligibility referrals with the coordinators.
Really quick question. You know how when parents go to our online screening on our website, is there a spot where any kind of feeding concerns would be touched?
They can write in there like what their concerns are.
Okay, but there's not something for them to like see and be like, yeah, I have problems with it.
No, because I would rather us determine that we need an eval versus the parents reading it. I would rather just have them call us and go out there and see them.
Okay.
Because sometimes parents, you know what you can read on the internet, and I would hate for them to not be like, oh, they're okay, because most parents don't
Well,
want
that's what I'm
anything to
concerned
be
about,
wrong with
yeah.
their kid. So, no, so
Okay.
it's just a real general form to get that intake started, but you guys will see a lot of these.
So is there
kids.
anything that, because I could see where a lot of parents might not understand that infant toddler would be a resource for a child that's not eating well.
That's eating baby foods at 2 years old.
Yeah, I mean,
Yeah, those.
that's what I wonder. So is there something that would just, I think that's probably the point Nadine was trying to make.
Probably a great question, maybe for team meeting. I don't want to take up any more
Yeah,
Megan's
right.
time. I know they don't have very much,
Yeah.
but we can talk about that in
Okay.
team.
So do you want to go over?
Yep.
I think they can just read through that.
Okay.
Yeah.
Yeah.
Okay. So, this just kind of outlines, when you have a typical picky eater versus a problem feeder, which would be somebody who would, want to be getting in for services or being seen by somebody. So your picky eaters will have a decreased range and variety of foods, but they'll eat more, at least 30 foods or more. Our problem feeders will usually have less than 20. Picky eaters, once they lose a food, they'll typically regain it within 2 weeks. Our problem feeders, once they're gone, they're gone. They're not gonna try that ever again. Our picky eaters will tolerate the new food on the plate, and they can usually at least touch it or taste it or interact with it in some way. Our problem feeders will be crying and falling apart and needing to leave the room, and I think that's a big indicator. That's a big one. The picky eaters will try at least one food from most food groups, texture groups, or nutrition groups, and they'll have those consistently, whereas problem feeders will refuse an entire category of foods. They won't eat any meat ever. They won't have any purees ever. And that's an important one too.
And what age range is this for where a child should be eating more than 30 foods?
That is a good question, because it does depend developmentally.
Yeah, I mean,
Yeah.
at one they
I would say that would be for kids who have all of the oral motor skills. And same with the ones from the, because if it's an infant or a small child
Right.
who's just learning purees right now, we're not going to be concerned about if they're not eating
But they won't have
crackers
good
yet.
Yeah.
Yeah.
We're gonna be looking
have to
more
read
like
through
the
it.
sensory piece or the positioning piece or what's going on, yeah. and then
That's a good
more
question.
the oral motor.
Yeah, I would say this is more for our established age, so our toddlers, for us anyway. Our picky eaters will add new foods to the repertoire within those 15 to 25 steps or less. It takes more than 25 steps for our problem feeders. So it's just a lot more work to get them to try a new food. Picky eaters will typically eat with the family, even if they're eating something different than what the family is eating. Our problem feeders will often eat something different and during a totally different time, because a lot of times we see the family has been just conditioned to focusing so much on the child. I think that a lot of times they're taking, like the parents like, oh, we're gonna eat later, and you see that a lot. The picky eaters are reported as picky eaters at their well child visits, sometimes, but not every visit. Our problem feeders, it's gonna be consistent every 3 months or 6 months. Whenever they're going in, they're always saying, oh, they're really picky, oh, they're really picky. And that kind of, that's an important one, because a normal developing child without feeding issues is gonna have those times where, gosh, they won't eat anything right now. And then, this PowerPoint gives us one tiny slide on treatment strategies, and then suggests that everybody attends the conference in order to learn treatment strategies. But I put a lot, so I'm gonna go through each one and give you ideas for at least the family meal, because I
That's so
think,
funny.
we're not doing a whole lot of, here's our therapy meal, we're gonna sit over here and implement the food hierarchies and all of those things that they can do in the clinic, but in our home setting, we do get to see a lot of family meals, and we do get to provide a lot of suggestions as far as the family meals, what they can be doing every day in their own home. So I'll go through some of those really quickly. So the first area of treatment is social modeling. So this is just basically modeling good feeding behaviors, making sure that the child is not the sole focus of the meal, so everybody's sitting around the table. And we're passing the food and we're commenting on what we're eating, and if they are touching the fork or picking up their cup, whatever, anything that's an adaptive behavior for mealtime, we're gonna be talking about that and ignoring the maladaptive behaviors. So throwing the food on the floor, or, you can be sure to, we're recognizing the siblings when they're taking a bite of something, or just commenting on our own behaviors, what we're doing. We're narrating the meal in a positive light. I know we all know this, but, not punishing the child, forcing the child, or bribing the child for any kind of eating or trying something. As soon as you start to punish or threaten or any of those things, then the adrenaline level is going up and the appetite is going down. So I think that's a good way to explain to families who tend to want to bribe or coerce in any way, is that you are upping that child's adrenaline and now their appetite's going away. So we're going backwards. We're not going forward at all. As far as structuring our meals and snack times, we talked about this a little bit, with providing a meal every 2.5 to 3 hours, and it can take up to 2 weeks before this new pattern of appetite awareness can kind of be regulated or kicked in. Try using, they suggest like a plain placemat. We want the food to be the whole focus of the meal. We don't need characters and all these distractions, so trying to use everything to be plain, but allowing one spot to be for that child so that it's consistent and that's, they can know what to expect with where they're going to eat as far as food. Creating that predictable routine is really important, so giving them a warning. It's 5 more minutes and then we're going to come sit at the table, or we're going to get ready to eat. Giving them a transition activity, possibly washing their hands, gives them some good proprioceptive input, and it can be the same thing they do every time before they come and sit at the table. Serving the food family style during the meal, so we're passing the food around, so even if they don't want it on their plate, they can at least maybe hold the bowl and pass it to their sibling or their parent. And then keeping in mind the amount of time for a meal, between 20 and 30 minutes. Max would be 40, but most little kids can't handle that long at the table. And then having them participate in cleaning up as well as prepping the food. So if they can put the food in the bowl to be served, that's a step. And then at the end, if they can throw away their food or blow it into the trash can, but getting that interaction throughout the meal. It's also important to, I know a lot of our kids have what we call crutches at mealtime, so like an iPad or a book or the TV on, and the parents use these as a crutch because it's a distractor and it gets them to the table. But trying to start the meal without the crutch, and then, maybe 5 minutes in you have to bring it out, or 10 minutes, and then kind of slowly weaning that crutch until it's gone. And then allowing for at least one highly preferred food at each meal, so that they have that level of comfort, but then they still are exposed to the other foods at the meal. As far as reinforcement, verbal praise is in the right amount is really what works the best. Reinforcing siblings, and we kind of already talked about this, any adaptive behavior at the mealtime. Playing with the food, passing the food, anything that they're doing to interact. And then the last area is accessing the cognitive ability of the child, so taking note of where they are cognitively. And there's age ranges, but for a lot of our kids, age ranges don't always apply. But for our 0 to 24-month-olds, they're typically in that sensory motor stage of cognition, so this is sensory, playing, touching the food, copying what you're doing. Everything is more physical versus pretend or anything like that. Our 2 to 5 to 7-year-olds, for us 2 to 3-year-olds, they are in more going towards that pre-logical. So you can do more playing with purpose with the food, or pretend, or they're really in that stage of magical thinking. And it's important to remember with those kids, you can't fight their magical thinking with your logical thinking. It just doesn't work. So they say fight magic with magic. So encouraging them through, you know, look into their imagination, what they're into, and all of those. And there is one slide after this about that. And this is our pre-logical. And there's, you know, it can be as simple or as elaborate with what you can do with food, and you can look on Pinterest for like a bajillion ideas. And we all have those parents who will do those things, but then sometimes you're busy, and so you just use what's on the plate.
So you said to keep things simple is that for the first 24 months, and then after, then you can do more, is that what you're saying? Because you were saying.
So like, were you saying with like the plate and everything?
No characters.
It should always, like, everything
Always
besides
should
the
always be
food
play.
should be simple.
Okay.
So the food is the focus of the meal. So the food can become the character or the Mickey Mouse or whatever. And that's gonna really appeal more to our pre-logical thinkers, our 3 to 5 year olds really. So we don't have a whole lot, but sometimes closer to 2, they're starting to really see those things, so.
Related to this, if you have ones with just toys that they have and they're bringing to the table, you can have them watch, like the toys are watching. That works really well, just throwing it out.
Yeah,
Yeah.
definitely. That's all we have.
Great info.
Oh, this is great.
Yeah, thank you.